Will you do the next one? It's so cool. Sorry. Okay. Our next presenter is Dr. Mika Ikeda, whose the title of the presentation is Standard Surgical Approaches for Keloid Treatment, a comprehensive review of outcomes at the Department of Plastic and Reconstructive Surgery, Kobe City Medical General Hospital.
Good afternoon, everyone. Nice to meet you. My name is Mika Ikeda. I'm a plastic surgeon from Kobe, Japan. For me, this is my first time to present at an international conference, so I'm so nervous. Please go easy on me. Yeah. So I have no conflict of interest to declare. So in the surgical treatment of keloids, as you know, recurrence after excision is a major problem and barrier to treatment. Although our institution is a public regional hospital, we established a specialized keloid outpatient unit in 2013. Since then, we have been providing systematic keloid treatment while conducting research on the pathogenesis of keloid in collaboration with Riken Institute, which is next to our hospital. You can see the poster on the next floor by Dr. Matsuzoe, my colleague. Depending on the condition of the keloid lesion, we offer surgical treatment combined with radiation therapy alongside conservative treatment while conducting long-term follow-up whenever possible. A retrospective analysis of these cases allows us to identify characteristics of recurrent cases, determine the minimum necessary follow-up periods, and evaluate the effectiveness of our systematic treatment approach. We retrospectively reviewed the medical records of keloid cases surgically treated at our department over a 12-year period from June 2013 to December 2025. Treatment methods included simple excision as well as flap surgery and skin grafting. Cases were classified by patient age, sex, and keloid location. And recurrent cases were identified from the surgical cohort, and their post-recurrence clinical course were analyzed. This study was approved by the IRB of Kobe City Medical Center General Hospital. After excluding 8 cases lost to follow-up after suture removal, 129 keloid cases underwent surgical treatment. The follow-up periods range from 1 month to 126 months post-operatively, and average was 30.9 months. There were 85 females and 43 males. Their age ranged from 4 to 81 years old, and the average was 41.6 years old. The highest age distribution was in their 20s, 32.8%. Keloid locations were distributed as you can see the diagram. The largest proportion of cases involved the ear. The following was in chest. We have been prescribing oral tranilast for prevention of recurrence after keloid excision. Although tranilast is an anti-allergic agent, it has been reported to have various effects on keloid, including TGF-beta inhibition, suppression of keloid fibroblast proliferation, reduction of ECM production, and anti-inflammatory effects. In this study, oral tronidazole was prescribed in 19% of cases. And among them, 14% discontinued due to pregnancy or side effects. Post-operative radiation therapy was administered in 96% of cases. Immediately after surgery, a custom-made shield designed with 1 centimeter margin was created. And treatment was initiated within 24 hours of surgery. 6 mega electron volt electron beam with 5 to 10 millimeter thick bolus was irradiated. For ear keloids, the dose was 16 grays in 4 fractions, while for other sites, the dose was 20 grays in 5 fractions. Here are some representative cases: chest, earlobe, abdomen, and umbilicus. In 77% of all cases, favorable results were achieved in several years after surgery. On the other hand, recurrence was observed in 23% of cases, 60 females and 14 males. Age ranged from 18 to 79 years old, and average was 41.1 years old. The higher age group was those in their 20s, 30s, and 40s, accounting for 66%. The recurrent rate by site was shown. Recurrent rate were higher in high-tension sites, including the chest, abdomen, scapula, upper arm, face, and the other trunk. In contrast, recurrence rate were lower in low-tension sites such as the ear and umbilicus. Fisher exact test demonstrated that high-tension site had significantly higher odds of recurrence than lower-tension sites, with an odds ratio of 3.57 and a p-value of 0.008. Recurrent cases were treated with local triamcinolone acetonide injections and corticosteroid tape application. The follow-up period after recurrence ranged from 9 months to 114 months. Clinical symptoms at the final evaluation were assessed using the 6 parameters of the JSW, Japan Scar Workshop Scar Assessment Scale, which were designed for judging treatment result and for follow-up, as you can see in this table. Overall, 76% of cases were rated as good or excellent, while 24% of cases were fair or poor. And their cases were on high-tension sites. Here are an excellent cases. I operated skin graft and simple excision from chest and scapular keloids. 1 to 2 years after surgery, small recurrence occurred. So immediately was taken triamcinolone acetonide injection and corticosteroid taping. Then after several years, excellent result was achieved. Meanwhile, there were 4 poor cases in this study. These are upper arm and the chest keloid to be evaluated poor. Although they were taken triamcinolone acetonide injection and corticosteroid taping immediately. It is shown recurrence was so severe, and 2 cases of them, although they are same patient, the keloid became bigger than the before operation. I compared the patient's average of age, gender ratio, onset average of age on the evaluation score, and the presence or absence of radiation and tronidazole. Regarding the effect of radiation and tranilast, it couldn't assess it because there was not control group. Although the sample size was too small to assess the statistical significance. These findings suggest that younger onset age and high tension anatomical sites may be risk factor for treatment-resistant keloids. Furthermore, to compare the patient with multiple keloids and those with simple keloids, multiple keloids were observed in 55% of all patients, compared with 63.3% of recurrent cases. Here, I contrast ear keloids and other side ear. Also, outside ear, patients with multiple keloid were 60%. Also, ear keloids generally respond well to treatment. In cases, 80% of recurrent ear keloids occurred in patients with multiple keloid. Finally, I investigated recurrence and the follow-up period. In half of cases, recurrence was occurring within 1 year after surgery. The recurrence was occurring between 4 and 36 months postoperatively, and no recurrence was observing beyond 36 months. Kaplan-Meier curve showed recurrence-free rate of 77.6% at year 1, 69.2% at year 2, and 63.2% at year 3. 90% of recurrences occurred within 2 years after surgery. Although the latest recurrence was observed at 36 months postoperatively. These are conclusion. Treatment combining surgery and postoperative radiation is an effective method that reduced the recurrence rate to 23%. High tension anatomical sites were associated with a significantly increased risk of postoperative recurrence. Patients with multiple keloids tend to have a higher recurrence rate after surgery than those with a single keloid. The tendency was also observed in the ear keloid. Early conservative treatment is effective for recurrent cases. However, keloids in high tension area and developed at use may be resistant to these treatment. The minimum recommended follow-up period after surgery is 3 years, but 3 years more is recommended for adequate recurrence assessment. Thank you for attention.
Thank you, Dr. Ikeda. Any questions for Dr. Ikeda?
Thanks very much indeed. Are you a surgeon?
Yes.
Yes. Yeah. The reason I ask you that, of course, you use 2 different fractionation regimes for the keloid in the ear and other parts, 4 and 5 fractions.
Yeah.
But your recurrence rate is still 23%.
Yeah.
It's too high.
It is what it is.
What do you say?
It is what it is. It's a number.
No, but I can say it's too high. It's very, compared to what we do, it's double what ours is.
Yeah, that's correct. I mean, you cannot replicate all the numbers everywhere.
Well, we've got it written down. But Michael, these are very important questions. And they have to be answered because our colleague is a surgeon, not a radiation oncologist.
Yeah, how can she answer? The data is the data.
So our goal is to detect recurrence.
But one can criticize data and talk about it. Tell us.
So I'm not a radiologist, so
You gave a lovely presentation. You don't mind me pointing that out, that it's a local high recurrence rate.
But according to my our radiologist in my institute, they said so. Yeah, so I'm sorry. So I prepare the cure.
I'm not being unkind. I'm just interested because you've done wonderful work. I can see that.
Yeah, but she is basically truthfully showing the recurrence rate. It is what it is.
Yeah, but Henry showed us it doesn't have to be what it is.
Your recurrence rate could be 0, but how can you answer that question?
Well, as a surgeon, it's difficult.
How can that question be answered? Can it be answered? Yes, somewhere about 20%, 15, 20%.
Sorry, what was that, Cash? No. As I said, I presented a much smaller data set, and it was 3%. And the series I presented was high dose rate brachytherapy. This is different. And this
they called the patients back.
Yeah, you had a longer follow-up.
You didn't call any of the patients back. You relied on patients calling you. Here in Kobe, they actually called the patients back, evaluated the patients with follow-ups of the 12 years. I mean, and I have seen patients who after 15 years of radiation have had recurrence. But it is the data. Data speaks for itself.
My experience is that all patients know when they've got a recurrence. They don't sit on it for long.
But that's not real.
It's a difference in
opinion. That's not real science. Science is that you call all the patients, see all the patients, and then know what's the recurrence rate. And that is say, this is the dropout, this is the percentage I see. And then you come up with a good data. And especially what she is showing, that the recurrence rate, even after 3 years, is higher. We did a brachytherapy study, and after a year it was quite low. And then at 5 years, it's way higher. So, but you have to see all the patients. And we all know that you have
You're overloaded.
A lot of experience, and your patients absolutely will love you, but you cannot say by anecdotal experience that there is not a high or low recurrence rate. And she shows the data that's higher than what we want.
But the recurrence rate that our colleague demonstrates is certainly within acceptable limits. It's much better than without radiotherapy. Can you speak in the loudspeaker? I can't hear you. I can't hear you.
Is it possible that this
Wait, start again. Is it possible?
Is it related to population specific? Because, that's a different subpopulation. You're treating a different.
No, it's related to fraction size, timing. She gets 4 or 5. It's as explained by Dr. Weatherburn. That's what it's related to.
I think that
anyhow, data is data. Data is data, and it speaks for itself. So there's
I think she has a wonderful data. That's it. And also, doctor, our patients can love us, but they are more prone to come back if they like you. Because the ones that don't like you, they are not going back to tell you that the keloid recurred. So this is true data, because she actually called everybody back. So that's what we've been trying to do too, because of course the ones that didn't recur, they will love you forever, and they will be back to do everything with you.
They all like me because they know I care. That's the truth.
It's not about liking you or not liking you.
Thank you.
This is scientific methodology that we were talking earlier, that you call the patients in, and she has done very respectfully, this is the recurrence rate. Accept it or not accept it. Then it's a totally new question as to why they think my recurrence rate is low, and by you, and why is Dr. Ikeda?
That's why we have a discussion.
Then that would be a whole discussion. Then first we need to look at your recurrence rate to see where that number comes from. Hers, we already know where it is coming from. And then there are a ton of differences. A ton of differences.
Yes, I agree. I agree.
A ton of differences. So can I have one more question, because we are running late in the day.
Yeah. Sure. A microphone, Henry.
Please make a short comment and one question. So since you have the microphone, go ahead and ask your question.
Yeah, just
ask your question.
Sorry, I'm going to ask the question first.
Short questions.
It's just in the ear keloids. I just quickly worked out the BED for 2.5, and it was just over. It's 41, and it was similar to those 2 series that I showed there, which had a recurrence rate of 19%. They were 41 or 42 BED 2.5. So the recurrence rate is similar to those groups. And that's the one for the ear keloids.
Right. Thank you very much.
Thank you very much for the presentation, and thank you for showing the poor results as well as the good results. I really appreciate that. Just a quick question. Obviously, we've seen the pictures of, I don't know if you can bring back to the slides where you show the pictures. You've mentioned that as soon as you see a recurrence, you inject them with steroids to see it would bring that down. Is there any reasons why, or do you actually do 5FU or do more RTs to see whether that would stem the recurrence? Thank you.
How would you treat the recurrence after radiation? So, yeah, well,
after recurrence, so when we find a recurrence, so yes, as a slight rate, so we applicate the tape, steroid tape, and if the recurrence became elevated over the duration, so we immediately take a corticosteroid, triamcinolone acetone injection.
And is there any cases where you would give 5FU, like a chemotherapy intralesionally, or radiotherapy? No.
No.
Sorry,
Radiotherapy is one time, so in my institution.
Thank you very much.
Thank you.
Thank you.
Thank you very much.